All right, well, good evening and welcome to tonight's Gastrointestinal Cancer CME series. I'm Dr. Jill Lacey and I'll be hosting our session this evening. This is the fourth and the final installment of our Yale CME series devoted to gastrointestinal cancers this spring. And tonight our topic is going to be cancers of the esophagus and the stomach. And I think this is really very timely as there have been a number of notable advances and changes in practice just over the last year or two, which we'll hear about tonight. So I think, as most of you know, the management of our patients with these cancers is complex and is highly multidisciplinary, involves our surgeons, radiation oncologists, and medical oncologists in many cases. And so tonight we have a speaker from each of these three therapeutic disciplines, and we'll get to hear their perspective on the field and updates in their areas. It's difficult to make these webinars interactive, but we certainly welcome questions. So please put your questions into the chat or the Q&A, and then depending on the flow and the time, we'll address questions all at the end or between the talks. So I'm going to be kicking off tonight's session with the first talk. And by way of very brief self-introduction, I'm a medical oncologist and I care for patients with gastrointestinal cancers, and I have a particular interest in tonight's topic, cancers of the esophagus and stomach. The title of my talk is Systemic Therapies and Clinical Trials in Gastrointestinal Cancers, Year in Review. There has been a lot of activity. So let me get my talk up. All right. So this is the fourth in our spring series. And our speakers tonight are shown here. And as I said, I'm going to be talking about systemic therapies and clinical trials with updates over the past year. Here are my disclosures. So tonight, I'm really going to be focusing on adenocarcinomas, and in particular, metastatic disease and first-line treatments. Our therapies have moved to being biomarker-driven, so I'm going to review the data with our PD-1 inhibitors, how we manage MSI-high disease, the recent data with antibodies targeting Claudin 18.2, talk a little bit about the so-called triple-negative subset of patients. And if there's time, I'll pivot to localized cancer and review recent data on the role of immunotherapy. I think it's worth mentioning the statistics. There are 27,000 deaths per year in the United States from esophagus and gastric cancer. So falling right behind prostate with 35,000 deaths and breast with 42,000 deaths. And those are much more common cancers with over 200,000 cases a year. So this is still, these are still lethal cancers, and so very much an unmet need. Most patients, of course, are succumbing to metastatic disease, where systemic therapy does play the central role in prolonging life in most patients. But there are selected cases where there's a critical role for surgery and radiation therapy, and we will be hearing much more about that in the next two talks. So here's a graphic that I borrowed from a presentation from a lecture at ESMO. And what's shown here are all the presentations at ESMO focused on gastric cancer and esophageal cancer. And this is really quite remarkable. For the ones focused on advanced gastric cancer and GE junction cancers, 6 of these presentations were large randomized phase 3 trials that are potentially practice-changing. So we have really moved into the era of biomarker-driven therapies for metastatic gastroesophageal adenocarcinomas. So what biomarkers do you have to have in 2023, 2024? There's really 3. You need PD-L1, you need to know the mismatch repair status or the microsatellite status, you need HER2 testing, and very shortly we probably also will need testing for Claudin 18.2. We currently at Yale are doing all of these testings reflexively. They're all done by IHC, so we get these results back very quickly. When do we need next generation sequencing? In the second line setting, when patients progress on their first line therapy, we really do need next generation sequencing. This is to look for genetic lesions that may allow us to match a patient with the clinical trial with the targeted therapy, and also to look for those rare genetic lesions for which we have tumor agnostic FDA approvals, such as NTRK, ELK, ROS, BRAF. So I'm going to start with the landscape with PD-1 inhibitors added to chemotherapy in the first-line setting in HER2-negative metastatic gastroesophageal adenocarcinoma. And shown here in tabular form are the 6 trials, all large randomized phase 3 trials that have been conducted globally and in Asia, looking at the efficacy of adding a PD-1 inhibitor to chemotherapy. And the chemotherapy in all of these trials is a platinum, either cisplatin or oxaliplatin or fluoropyrimidine, either 5-FU or Xeloda. And I think what really stands out about these trials, and I think this is such an impressive body of work with contributions from thousands of patients around the globe, is that the results are remarkably similar. Hazard ratios in the all-comer populations in these studies around 0.7, a little bit better in the PD-L1 positive subsets, and PD-L1 positivity is defined with different assays and cutoffs, so that's been a challenge. All of these PD-1 agents and the PD-L1 from the Gemstone 303 study now have regulatory approval in different countries around the globe. And in the United States, we, of course, have nivolumab from the Checkmate 649 study in esophagus, GE junction, and gastric. And we now have Keynote from the Keynote 590 and most recent Keynote 859, giving us regulatory approval in the United States for pembrolizumab, not only in esophageal cancer, where we first had approval, but now also in gastric cancer. It should be pointed out that there were 2 negative studies earlier on. The first with Keynote 62, that was also pembro versus pembro plus chemo versus chemo, and that was a negative study. I don't think we still fully understand that. And the attraction for was like the Checkmate 649 study conducted in Asia, and the survival was exceptionally good in both arms, but that was a negative study. And I don't think we fully understand that. So what do these studies tell us? They all confirm benefit of adding PD-1 inhibitor to chemotherapy. They all give us remarkably similar outcomes. Patients in the all-comers population are living on average about 2 months longer, and in the PD-L1 enriched populations, anywhere from 3 to 6 months. And the benefit is greatest in those patients who are positive for PD-L1. I think the big question that we face is there a PD-L1 value or cutoff that we should use to exclude patients from receiving PD first line? And this is a confusion. And the confusion is reflected in the discordance between FDA regulation and NCCN recommendations. So these are highlighted here. So nivolumab, for example, is a category 1 recommendation from NCCN if the CPS PD-L1 is 5 or greater, but the FDA has approved it in all comers. And it is a similar story with pembrolizumab. The NCCN giving category 1 for CPS of 10 or greater, and the FDA giving approval in all comers, PD-L1 agnostic. So why is there this discordance? And I think it reflects the fact that PD-L1 remains an imperfect biomarker. We know for sure that there is both anatomic and temporal heterogeneity, that you can get different results from a little biopsy and a surgical specimen. These studies have used variable reagents, assays, and different PD-L1 cutoffs for their trial endpoints, which further adds to the confusion. We also know that the age of the specimen can impact the results, and we know for sure that there is both inter and intra-observer variation in the readouts. So our pathologists tell us that it's a good qualitative test. You can tell whether it's present or absent, but it's much less good as a quantitative test. So I think all of this data is certainly very positive and exciting. Just to remind you, we had no improvements in survival in gastroesophageal adenocarcinoma for the preceding 20 years. The best we were doing was with systemic chemotherapy, with survivals hovering around 10, 11 months, but under a year. So this is really a breakthrough. But good news is always tinged with a little bit of bad news. And so this year we heard the long-term follow-up from both Checkmate 649 and Keynote 590. So here's the Checkmate 649 4-year follow-up. And at 4 years, you can see that even in the PD-L1 CPS positive group, the 5-year survival is under 20% at 17%, and the all-comer group 13%. So still, the majority of our patients are not having long-term survival. And then if you look at the progression-free survival in the best subset, the PD-L1 positive group, what you're looking for is that plateau, which would suggest that these patients are cured. There does seem to be a plateau, but it's down at about 12%. This does reflect true cure, but again, want to be. And it was basically a similar story with Keynote 590. The results actually are not quite as good in the adenocarcinoma subset from this study, with just a 7% 5-year survival. And we're not seeing that plateau in the progression-free survival here. So really, there's still much work to be done. This is a major breakthrough, but we cannot pause. So really where the field is moving is adding other biomarker driven targets to chemo and PD-1 inhibitors. So I've shown here, just as an example, 4 studies that we have open here at Yale or about to open, again, using chemoimmunotherapy as the control arm and adding, in this case, biologics to it. We have some very good preliminary data targeting TIGIT with domvanalimab and 2 studies at Yale. One is actually a phase 3 study, and that accrual has completed. So we'll be getting a readout from that certainly within the next 2 years. We also have the study looking at adding the FGFR2b monoclonal antibody. We call it BEMA. It's easier to pronounce. So FOLFOX plus Nivo with or without BEMA, and that's a high priority study. About 30% of our patients carry this biomarker. And then an interesting study looking at adding anti-TGF beta to Xelox plus nivolumab. So I'm going to shift now from HER2 negative to HER2 positive disease. We have had a practice change this past year, so I will review that. So as you know, for the last 15 years or so, the standard of care for HER2 positive metastatic adenocarcinoma has been trastuzumab plus platinum fluoropyrimidine chemotherapy based on the Toga trial. Then in May of 2021, our FDA granted accelerated approval for the addition of Pembro to this doublet, and that was based on interim analysis of the Keynote 811 study, primarily and only actually on the response. So the response rate with the addition of Pembro was an impressive 75%, and in the control arm with the doublet, 50%. So based on that, the FDA gave accelerated approval. So we now have efficacy in terms of the 2 primary endpoints, PFS and OS, from this study that was presented last year and is now published. So here's the design of Keynote 811, very straightforward, plus chemo versus trastuzumab plus chemo. The dual primary endpoints were over OS and PFS, which we did not have for the accelerated approval. And the eligibility are shown here. It should be noted that in this study, 85% of the patients were PD-L1 positive with a CPS of 1 or greater, and only 1.5% were MSI high. And this study did meet its primary endpoint in terms of an improvement in progression-free survival. So that was a relief because we did not know that. And in their subset analysis, however, in the small percentage of patients that were PD-L1 negative, there was really no hint that there was benefit from Pembro. It was also a positive study in terms of the second primary endpoint of overall survival. I have to say I was a little disappointed with these Kaplan-Meier curves because based on the responses, I thought we would see more of a separation, but nonetheless, this is statistically significant with a hazard ratio of 0.81 rather. And so in November of last year, the FDA revised its existing indication for Pembro and now has restricted its use only to patients whose tumors express PD-L1 with a CPS cutoff of 1 or greater. And fortunately, that is the majority of our patients with HER2 positive metastatic gastroesophageal adenocarcinoma. So now I'm going to shift into patients who have microsatellite instability high metastatic gastroesophageal adenocarcinoma. What is the optimum regimen for these patients? So we actually see a fair number of patients, not an insignificant percentage of patients, have tumors that are microsatellite instability high, somewhere between 10 and 20%. As in colon cancer, it's enriched in the localized disease, close to 10%, and in the metastatic disease, lower at about 3 to 4%. As in colon cancer, it's also enriched for our older patients and also in females, so a very similar story. So analogous to colon cancer, we have to ask the question, what is the efficacy of immune checkpoint inhibitor therapy in gastric cancer? We know in MSI high metastatic colon cancer, immune checkpoint inhibitors are extremely active, and in the large randomized phase 3 trial in that disease, Pembro was proven to be more effective than chemotherapy and is now the standard of care in the first-line setting. So we do not have a randomized phase 3 trial in this disease, nor will we ever, most likely. But we can go back and look at the Checkmate 649 and the original Keynote 62 studies and pull out the MSI high patients, and that of course has been done. I'm showing you the data. And just to remind you, in Checkmate 649, they had a third arm of Ipi-Nivo. They did not go forward with that arm because it was negative in the general population. And similarly, in Keynote 62, chemo plus Pembro, and Pembro alone. And again, we did not get regulatory approval at the time of the Keynote 62 presentation. So I think you can see from these Kaplan-Meier curves that immunotherapy has a huge impact in MSI-high metastatic gastroesophageal adenocarcinoma. These Kaplan-Meier curves are what we all dream of, hazard ratios of less than 4, whether it's with IO alone, Pembro, or Ipi-Nivo, or with chemo plus Nivo, or chemo plus Pembro. So this is impressive. They did not do in any of these studies a comparison of IO alone against chemo IO, but I think if you look at these Kaplan-Meier curves, the results really do look very similar. Now, these numbers are small, so confidence intervals will be large, but this is very impressive data, given that it's very consistent. So we now have prospective data that is validating this observation. So this is a study that was done in Japan with a very optimistic name, No Limit. And in Japan, they screened 935 patients over 2 years for microsatellite instability and identified that 3%, or 29 patients, a preponderance of elderly patients and females. And patients were treated here with Ipi-Nivo, Ipi low dose, 1 mg per kg every 6 weeks, and Nivo every 2 weeks for up to 2 years. The primary endpoint here is response, so we got a pretty quick readout. Secondary endpoints we're waiting for, PFS and OS. So here we have the responses, and this is the waterfall plot that we've all come to expect with immunotherapy in MSI high cancers, with the vast majority of patients having some cytoreduction, seeing deep responses, and an overall response rate of an impressive 62%. So we don't yet have PFS or OS, and that's pending, but certainly, again, this is very reinforcing about the effectiveness of immunotherapy in gastroesophageal adenocarcinoma as in colon cancer. So how should we treat these patients? What's the optimum regimen? I think we have to say that inclusion of immune checkpoint inhibitors, of course, is essential, irrespective of the PD-L1 CPS in this case, and is the standard of care. And I think you have 3 options: chemoimmunotherapy, FOLFOX/Nivo a la Checkmate 649, or pembrolizumab with chemo from Keynote 62. You can do Ipi-Nivo from Checkmate 649 or No Limit, and you also can do pembrolizumab monotherapy. I'm just going to mention very briefly a study that was presented at ESMO that I thought did not really get just quite enough attention, and maybe because it's not biomarker driven, just old-fashioned cytotoxic chemotherapy. But this was a study that is addressing the question of triplet chemotherapy with the FLOT regimen versus the standard 2-drug regimen of FOLFOX. And as you know, we use FLOT in the perioperative setting, so it's surprising that we're not using it in the metastatic setting. So this is the GasFox study done by our French colleagues. And the design here is very straightforward. This is for HER2-negative patients, of course, not biomarker-driven with respect to PD-L1. And the randomization is to what they call FLOT-FOX, but it's really basically FLOT versus FOLFOX with a primary endpoint of progression-free survival. So this was a large study. And this was a positive study by every endpoint: progression-free and overall survival with hazard ratios that are good enough, statistically significant. And very importantly, the French included a health-related quality of life analysis, time to deterioration, And that favored, interestingly, FLOT. And that is probably because delaying progression is associated with better quality of life, despite some increased toxicity from the addition of a third cytotoxic. So I thought this was interesting. The author's conclusions are shown here, that FLOT demonstrated a significant improvement and meaningful improvement in progression-free and overall survival and response versus FOLFOX in patients with advanced adenocarcinoma, HER2 negative, of course. The safety profile was there were no red flags, nothing unexpected, and better longer time to deterioration and quality of life. So I think we can conclude that FLOT could be considered as a new first-line treatment option for those patients who are what I often refer to as triple negative, so negative for PD-L1, HER2, and microsatellite, they're microsatellite stable, who are otherwise eligible for a triplet chemo regimen. So I think the next steps would be, should we be adding biologics to FLOT? I'm not sure that will happen. There's so many potential studies that we can do, but I think this is something to think about in that biomarker negative patient population, which is getting to be, and soon will be with the approval of the Claudin-targeted antibody, a much smaller slice of the pie. So now we're going to turn to really what was a big story last year, and that is targeting Claudin 18.2 with zolbetuximab. And there were two studies, GLOW and SPOTLIGHT, which were very similar in their design and gave almost identical results. So I'll talk about SPOTLIGHT. This was presented last year at ASCO GI and then has been published in Lancet. So this was a randomized clinical trial of FOLFOX, no Nivo, no Pembro. So FOLFOX is the control, plus or minus zolbetuximab in the first-line setting, again, the HER2 negative patient population. Just a little bit about zolbetuxin and Claudin. So Claudin is a tight junction protein. It's buried in the tight junctions in the gastric mucosa. And when mucosal cells undergo transformation and become malignant, Claudin becomes exposed and then becomes a druggable target. And zolbetuximab is a monoclonal antibody that targets Claudin, and it apparently induces both antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity. So this is the design, a randomized phase 3 trial, placebo-controlled, primary endpoint, progression-free survival. It was not stratified for PD-L1, but they did a post-hoc analysis for PD-L1, and that's shown here. 13% of patients were CPS 5 or greater. Obviously, patients had to be Claudin 18.2 positive, and the definition was greater than 75% of tumor cells positive. And in this study, about 38% of screened patients were Claudin positive. 84% of patients had prior gastrectomy, and esophageal adenocarcinomas were excluded. So this is not quite the population that we see in the United States. Probably most of our patients have not had a prior gastrectomy. And again, of course, no PD-1 inhibitor. So this was a positive study with an improvement in progression-free survival with zolbetuximab added to FOLFOX, 10.6 months versus 8.7 months. Good hazard ratio, 0.75, that Kaplan-Meier curve split. And it was also positive for overall survival, significantly longer. So there are a couple of notable observations here. So one is that the survival of zolbetuximab was remarkable at 18 months. That's the longest survival that we've seen in any randomized phase 3 trial. But the survival in the placebo group with FOLFOX was also remarkable at 15 months. We've not seen that in any other randomized trial. So that has been a head scratcher. It probably reflects patient selection. There was some question about whether Claudin 18.2 is a favorable biologic marker, but it does not appear to be so. So we have FOLFOX plus Zolbe and FOLFOX plus Nivo or Pembro. And so obviously we're already thinking, which one are we going to use? And you can't help but do a cross-trial comparison. So looking at the comparative data from Checkmate 649, if you look at the delta in terms of median survival, it's really about the same with these two biologics, about 3 months, 2.7, 3.3, very similar hazard ratios. Of course, in Checkmate 649, you saw the more typical survival in the control arm of under 12 months. So in terms of the secondary endpoints of overall survival, in the subset analysis, I think there are a few noteworthy findings. So the benefit is much more impressive in patients who have had a prior gastrectomy. And there did not appear to be benefit in patients with GE junction cancers. And again, that is the bulk of the patient population that we're seeing. And there was actually no difference in response rate or duration of response, which is also a little perplexing, although we have seen that in other studies where there's an improvement in PFS and/or overall survival. In terms of toxicities, what really jumps out with Zolbi is nausea and vomiting, particularly at the beginning. And this may be an issue as this is rolled out into the real world and when combining with other drugs. So conclusions are this biologic certainly improves PFS and OS when added to FOLFOX compared to FOLFOX. Nausea and vomiting is going to be an issue, and it is a potential and will be soon a new standard for Claudin positive, HER2 negative. I'm leaving PD-L1 off the list here because we don't know quite what to do with that just yet. Metastatic gastroesophageal adenocarcinoma. So this study has provoked obviously a lot of questions. One is about that unprecedented survival in the control arm, probably reflects patient selection. Many patients coming into the study from Korea and Japan, where we often see better survival. Little or no benefit in the GE junction patients, and esophageal patients were excluded, and less benefit in patients who have not had a total gastrectomy. And again, we don't see an improved response rate or duration of response. We don't know how efficacy relates to PD-L1 status. And of course, we are already thinking about which biologic we're going to be choosing for our patients once this has regulatory approval in the United States. This was followed very shortly by results from a twin study. This is GLOW, almost identical design, except the chemo backbone here is capecitabine and oxaliplatin. More patients were coming into this study from China. And here, the survival of the control population reflects what we are used to seeing, around a year. So very similar results with GLOW. So here are the two studies stacked up against each other, almost identical hazard ratios for overall survival and progression-free survival. So there is no question that this combination is a potential new standard of care. We are awaiting FDA approval. We're not sure why it has taken this long. I don't have the inside story on that. The question is really now, do we use Nivo Pembro or do we use Zolbi in our Claudin positive patient population, which is 75% of patients, I'm sorry, 40% of patients. And should we restrict its use to the PD-L1 negative patients? So we're certainly waiting for data on PD-L1 inhibitors or PD-1 inhibitors with Zolbi and chemotherapy, and that's coming. And we're going to certainly be interested in its activity in the second line setting, because when this is FDA approved, most of our patients will already be undergoing therapy with chemoimmunotherapy. So there's much to do in terms of targeting Claudin 18.2. We're certainly going to want to be looking at combining it with PD-1 inhibitors, and the Illustro trial is already ongoing looking at that. We want to know what its activity is going to be in the second line setting. Can we combine it with second line chemotherapeutics? And there are already Claudin 18.2 targeted antibody drug conjugates that are in the clinic and looking promising. So much work to be done, and this story will continue for many years going forward. So here's where we are now with biomarker-driven therapeutics in the metastatic space. 5% of our patients will be MSI high, and of course, all those patients will get immunotherapy. 20 to 25% will be HER2 positive, and they will get a doublet if they're PD-L1 negative, or a triplet with Pembro if they're PD-L1 positive. But there's a huge slice of the pie, 70 to 75%, that's MSI microsatellite stable and HER2 negative. And here we now have emerging biomarkers. Of course, we have PD-L1. We're going to have Claudin as a biomarker. We hopefully will have FGFR2b. That study is underway, looking at BEMA with chemotherapy and Nivo against FOLFOX Nivo. Many of these patients will have overlapping biomarkers. So how will we choose? And again, we're just going to have to see clinical trials and how the data plays out, because I think right now There are no rules for how to prioritize. We haven't faced that issue yet, but we will once zolbetuximab is approved. And I think, of course, the new standard for clinical trials in terms of the control arm still does have to be chemotherapy with PD-1 inhibitor. So takeaway points. Is all of this data clinically relevant? I would say yes, which is why I presented it. A biomarker-driven approach is absolutely the standard of care in metastatic disease, and this is going to continue to evolve. Chemoimmunotherapy is the standard of care for PD-L1 positive patients, pending approval of zolbetuximab. But zolbetuximab plus chemotherapy will become an option for the Claudin positive patients. And then Claudin, I think, is going to be a very important emerging new biomarker and target. Is this practice changing right now? Well, I think for the MSI high patient population, I think we can be very comfortable using ipi-nivo or pembro as well as chemoimmunotherapy, and that is now in the NCCN guidelines. For HER2 positive disease, the addition of pembro is now restricted to PD-L1 positive patients, CPS 1 or greater. And for the microsatellite stable HER2 negative patients, we still have much work to do, and we have to consider all of those patients for clinical trials, both PD-L1 negative and PD-L1 positive. So I think I have about 2 minutes. So I will just very briefly mention what's happening with localized gastric cancer. So this is gastric cancer, not esophageal, that I'm focusing in on here. And as you know, the standard of care for about the last 5 or 6 years has been perioperative FLOT, prior to that perioperative ECF. And of course, we are now looking at adding checkpoint inhibitors to perioperative chemotherapy. There are 3 large randomized phase 3 trials ongoing looking at this. Dante with the addition of atezo, Keynote 585, which has been read out, adding pembro, and Matterhorn adding durvalumab. And we did hear about the results from Keynote 585 this year. This, of course, was a disappointment, although the pathologic CR was higher with pembro, as it has been in the preliminary data with Dante and Matterhorn, at least in Keynote 585, that did not translate into an improvement in overall survival. Those curves are pretty much on top of each other, and although the curves do split in terms of event-free survival, this did not achieve statistical significance. So we are not yet ready for including PD-1 inhibitors with perioperative chemotherapy. I would note, though, that again, in the MSI subset, there was an impressive, at least pathologic response with the addition of immunotherapy. So not ready for prime time. We're waiting for the event-free survival and overall survival from Matterhorn and Dante, and we'll see what that reveals. For MSI high gastroesophageal adenocarcinoma, what is the status of immunotherapy, and is this ready for prime time? And yes, we think possibly, with careful patient selection, I would add. And the reason for that is that this patient population has an extraordinarily favorable prognosis with surgery alone, and this is true for colon cancer, so the story is repeating itself. And you can see in these curves from 2 studies, MAGIC and CLASSIC, that the MSI high patient population did extremely well with surgery alone, and in fact did less well with the addition of chemotherapy. So that raised the question as whether we should not be using chemotherapy at all. Now, I think the FLOT regimen may have more activity in MSI high disease, so I'm not sure we should conclusively jettison chemotherapy, but I think this is a little bit sobering for this patient population. So we do know that the path CR in patients who get FLOT and immunotherapy is extremely high at 60%. This is from the Dante study. And we now have a prospective data from the Gerkornio, the PGIS study, looking at neoadjuvant ipi-nivo and then adjuvant nivo. And this is, of course, small numbers, but what they observed was a very high path CR rate, similar to what was observed in Dante at 59-60%. So this is impressive. We do not have long-term follow-up, so one has to keep that in mind. And it is important to see how these patients do long-term to ensure that we're eradicating microscopic metastatic disease. So the NCCN now does include neoadjuvant or perioperative immune checkpoint inhibitor therapy into their recommendations if the tumor is MSI high based on this still somewhat limited data, small numbers, but I think very compelling with these cautionary notes of proper patient selection, recognizing the very favorable prognosis with surgery alone. So who should we expose to an immune checkpoint inhibitor and those risks, albeit small. We don't have long-term follow-up, and I think this is an area where we're going to need more follow-up. So in localized disease, what's practice changing is I think we can feel comfortable using immune checkpoint inhibitors in the localized setting with careful patient selection, tumor board review, and so forth. And in the microsatellite stable patient, there's no role yet for PD-1 inhibitors. And that concludes my presentation. And thank you for listening. And I do have to acknowledge all of the authors for the figures that I borrowed, and ESMO and ASCO as well. So I will stop share. And because I went a little bit over, I think what I will do is save some questions for the end. And we will turn now to our next speaker. And I am really very delighted that we have Dr. Kiran Turaga joining us tonight. Dr. Turaga is a professor of surgery here at Yale and chief of our division of surgical oncology. Dr. Turaga joined our Yale community 2 years ago. We're very fortunate. He came to us from the University of Chicago, their laws. And he is a renowned expert in the treatment of peritoneal carcinomatosis, which, as he will tell you, is a huge issue in advanced gastroesophageal adenocarcinoma. So his enormous expertise to Yale, where he's already in a very short period of time built a very robust program for treating patients with peritoneal carcinomatosis, including HIPEC, which we'll hear about. And again, just a pleasure to have Kiran here tonight. So Kiran, I will let you go ahead and share your screen.
Thank you, Jill. Thank you, Kim. It's nice to see both of you on Zoom, and for all of you who are attending, thank you for taking the time in the evening. I know as the weather gets better in the Northeast, it's always something to join webinars in the evening, and hopefully this is valuable for all of you. So I'm going to speak a little bit about the multidisciplinary management of gastric cancer metastases, and specifically peritoneal metastases. I don't have any relevant disclosures for this. So I have some good news and some scary news. The scary news, of course, which I think we all know, is that gastric cancer is one of the most fatal cancers and is the fifth largest, is the leading cause of death and the fifth most common cancer worldwide. And about a third to half of these patients will develop peritoneal metastases, and often a third of them are actually synchronous or at the time of diagnosis. And I think over the years, we've gotten better at understanding peritoneal metastases for gastric cancer. Now in treating any patient with gastric cancer, we often do laparoscopies, we're doing washings, we're looking for peritoneal cytology. And I think these concepts have become so much more common that our identification of peritoneal metastases has also gotten somewhat better because of the way we treat these patients. The good news is that the death from gastric cancer in Connecticut has actually gone down and had the highest percentage decrease over this last year. So I think it's a remarkable feat in the state of Connecticut itself. The problem generally that we have with peritoneal metastases, and I think also with gastric cancer, is the fact that the sensitivity of CT scans is incredibly low at picking up peritoneal disease. And so it manifests itself in a few different ways. One, when you have patients with, say, early stage gastric cancer, the rate of peritoneal metastases is low, so that group does okay. If they're locally advanced, so T2 or higher, N1 or higher disease, they can have peritoneal metastases at a variable rate, like about a third of them can have it. And so we do laparoscopies and we have to look for disease in those folks. But in patients who have metastatic disease, these patients could manifest either as ascites dominant, so with fluid, in which case you can actually see it on scans, or they could be nodular, where you don't actually have ascites. And those are the folks that are difficult to enroll on clinical trials. And in fact, many patients with gastric cancer are with peritoneal metastases, even though a dominant site of metastases, are often excluded because you don't have resist measurable disease in that. And I think when you think of, peritoneal metastases, they tend to have a worse prognosis than than even, say, visceral metastases. And if you look at sort of three of the big trials, the Checkmate 649, Spotlight, and Toga that, Jill just kind of talked about, when you think of the progression-free survival or overall survival, it's still something that is quite humbling for all of us that take care of patients with metastatic disease. So I think it is something where, we have opportunities of thinking about this disease somewhat differently, and to think about how can we actually enhance our efficacy of therapies in these patients. So this is a nice figure that one of our faculty members who's going to be joining us soon, Dr. Sundar from Singapore, had put together in this review in JCO. And so I thought it's a very nice figure to kind of just think a little bit about the biomarkers that are associated with gastric cancer peritoneal metastases. And so if you think about it, there's four big components. There's the tumor-related factors. So I think we all kind of know a little bit about the genomic analysis and thinking about things, but there's clearly the epithelial mesenchymal transition. There is the Hippo pathway that is involved in gastric cancer peritoneal metastases. So that's one set of biomarkers for the tumors themselves. There's the peritoneal microenvironment where you actually can see mesothelial mesenchymal transitions, and you can see immune cells that are altered and neovascularization that occurs along with peritoneal metastases. But two factors that are very remarkable is the paracrine factors. So we know that ascites is incredibly prognostic for patients with gastric cancer with peritoneal metastases, and has cytokines, chemokines, growth factors, which all contribute to that negative prognosis. And then, of course, biomechanical forces. As surgeons, when we go in and we look at it, we see different sorts of fluid pressures, solid pressures, and so different distributions of gastric cancer peritoneal mets. And we don't have a good way of predicting which patient would get peritoneal metastases, even though there have been signals looking at it. We know that when primary tumors express mesothelin, or when they have things like SYT8 or 13 in both the primary tumor or in the peritoneal fluid, they're more likely to have peritoneal metastases. Or again, things in the TGF-beta pathway like CABN2 in the primary tumors, they could predict. And so there are some gene signatures that folks have developed, including 6 gene panels, to identify the rate of peritoneal metastases from a primary tumor, but we're not quite there yet for prime time. And the question is, if you think of peritoneal metastases, so a third of the patients will get synchronous peritoneal metastases, so metastases at diagnosis, but the other patients will actually get peritoneal metastases in a metachronous fashion, which means that they've had a gastric cancer diagnosed, resected, and then develop peritoneal metastases. And the problem is we're not very good at preventing peritoneal metastases. So these are randomized trials that have examined this question of giving adjuvant chemotherapy to reduce the rate of peritoneal metastases. That's the AXE-GC classic and JACRO trials, which have used some version of S1. These are all Japanese trials, when S1 is akin to a fluoropyrimidine that we use over here. So it's basically S1, and one trial was positive in a small sample, but in two larger samples using either Capox or docetaxel plus S1, we weren't very good at preventing peritoneal metastases. So this is a big issue that A, it's hard to detect, B, they're hard to put on clinical trials, C, it's difficult to prevent metachronous development of this. So it creates this incredibly tough population where thinking about disease is difficult. And the unfortunate thing is many of these patients develop malignant bowel obstructions, which are incredibly debilitating for patients, cause incredible amounts of suffering, and ultimately early demise. And so it is this sort of vicious cycle where we can't predict, and then patients develop peritoneal mets and bowel obstructions. And so I think the management of patients with peritoneal metastases really requires a multidisciplinary approach. This is where we need an approach where surgeons, medical oncologists, radiation oncologists, our support teams, social workers, nursing, dietitian, really have to get together to take care of a patient. And we're happy that we have a program such as this here at Yale, where we're able to take care of patients. And I think the concept of doing surgery in the setting of metastatic disease is something that is being explored more and more. And I think I'll share some data with you about the role of surgery and that of intraperitoneal chemotherapies for patients with peritoneal metastases. But surgery, quite often, as we've learned over the years, like for even gastric cancer surgery, doing the right type of surgery with the right type of lymph node removal is critical to patient survival and essentially to, in fact, recovery from that surgical procedure. And similarly, I think doing cytoreductive surgery where proper techniques of doing peritonectomies, removing the lining of the abdomen is essential to be able to provide a definitive care for patients with gastric cancer. And our field has evolved so much that now we have three modalities of delivering intraperitoneal chemotherapy. We have HIPEC, which is hyperthermic intraperitoneal chemotherapy, where chemotherapy is delivered at one time at the time of the operation or the cytoreductive surgery, and heated chemotherapy is circulated inside the abdomen for about 90 minutes and 60 minutes in some protocols, and then it's washed out. Catheter-based IP chemotherapy, where a port is placed inside the abdomen and chemotherapy is infused at frequent cycles, usually IP paclitaxel, which has been shown to have remarkable efficacy in some of these tumors. I'll show you some data on this. And then PIPEC, which is aerosolized intraperitoneal chemotherapy, which is currently being investigated in looking at a mechanism of delivering aerosolized chemotherapy that can actually distribute through the entire peritoneal cavity and has shown some promise in some early preclinical data. And so this is sort of how we do HIPEC. We do a fair number of these procedures here at Yale, and then also the way of doing it laparoscopically. So we have many different ways of thinking about this. But if you think at, some trials, randomized trials that have looked at the role of intraperitoneal chemotherapy, you can see a trial that was done by Hinori Yoshigami in Japan, the Phoenix GC trial, which randomized patients to getting intraperitoneal paclitaxel with systemic chemotherapy versus systemic alone, so S1 and cisplatin as your control arm. And what was remarkable that when stratified by ascites, we found the IP arm had a 3-year survival rate of almost 22%, which is very different than when you think about, say, any other gastric metastases trial. So it was a very interesting concept that there started to be a tail of the curve in the Phoenix GC trial where patients got IP therapy. So even though the trial itself, the overall endpoint was not met, the secondary endpoint created the Phoenix GC2, which is actually ongoing right now for this population. And when you think of Western populations, the CytoChip study looked at patients who had cytoreductive surgery or cytoreductive surgery plus HIPEC for patients with gastric cancer. And this is a propensity matched analysis in this setting. And again, what is interesting, and the part that I'd like to kind of bring everyone's attention to is the tail of the curve. So yes, the median survival is longer. Certainly, there's some issues in this because this was not a randomized study. And so therefore, there are issues of selection over here. But what is interesting is that in this cohort of patients with gastric cancer with peritoneal metastases in the setting of having cytoreductive surgery and HIPEC, at a 5-year mark, you still had about 20% of patients alive, which is something that wasn't quite seen with standard of care therapies for peritoneal metastases. So it's a very interesting concept of the delivery of IP therapy for patients with that. And then finally, the recent randomized trial, the GastroPEC trial, again showing a similar sort of effect size. So this trial did not completely accrue. There was a difficulty in accruing this trial because of equipoise for HIPEC and in patients, actually. And this trial was done by Beata Rao at the Charité Hospital in Germany. But what they found was, again, similarly at the 3-year mark in patients who underwent cytoreductive surgery and HIPEC, the survival rate was significantly higher than the groups that did not receive intraperitoneal chemotherapy. So a very fascinating sort of a space where the effects of intraperitoneal chemotherapy for gastric cancer seem to certainly suggest some benefit for patients. And one of our residents, Sam Butinsky, along with Craig Gunderson, looked at a meta-analysis and did this sort of meta-analysis looking at both observational and randomized studies. And again, the error bars still overlap or come close to zero, but tend to favor surgery with intraperitoneal chemotherapy in the management of patients with peritoneal metastases. I think one of the concepts that we've been very interested in is distinguishing patients, those that would be those that would benefit from local regional therapies like surgery and intraperitoneal chemotherapy versus those that have widely metastatic disease in which giving local regional therapy probably doesn't make any sense. And one of the things that is of interest to us is the use of cfDNA as a marker of prognosis. And we've shown previously that cfDNA, when it stays negative or is very low, is quite indicative of a good prognosis, even in settings of peritoneal metastases. And so we have a clinical trial that we're hopefully going to be opening very soon here at Yale, but the trial is a very simple concept trial. It's different than the Regatta trial, which was a randomized trial looking at patients with gastric cancer with metastases who just underwent a gastrectomy. This is closer in concept to another trial called the AIO FLOT3 trial, in which patients with oligometastatic gastric cancer are randomized to undergoing either local regional therapies that include surgery, radiation, ablation, things like that, versus getting standard of care therapy alone, with the hypothesis that by doing local regional therapies in addition to systemic therapy, we would improve the survival of patients by almost twofold. So the hazard ratio for this is 0.6 for the trial. So I think hopefully we'll have this trial open soon. And so for patients we have oligometastatic gastric cancer, we'll have an option of thinking about local regional therapies along with surgery. And then when you think about iterative intraperitoneal chemotherapy, there's two ways of delivering this. It's either through a catheter-based called iterative NIPEC, where you iteratively give intraperitoneal paclitaxel. And so this is a study which is recently published by Kobayashi in 2023, where a third of the patients who had metastatic gastric cancer initially considered unresectable, who got S1 cisplatin and intraperitoneal paclitaxel, were able to undergo surgery, and the median survival was 42 months in this trial. Now, again, this is the Asian gastric cancer, so kind of makes a slightly different case. But this sort of effect is seen in many of the other studies as well, including studies, but several of those from Asia as well. Another way of approaching peritoneal metastases is an approach where every 6 weeks, patients are given intraperitoneal HIPEC with cisplatin and mitomycin. And this was explored in a phase 2 clinical trial at MD Anderson, where they found that for patients either with cytology positive disease or low burden peritoneal mets, when they had repetitive intraperitoneal chemotherapy and they turned negative in cytology and then they underwent cytoreductive surgery, these patients did better than those that did not have cytoreductive surgery or the iterative HIPEC. So fairly interesting concept, but the median survival was still sort of somewhat humbling, except in the concept of giving patients IP paclitaxel. And what is interesting is right now there are several trials that are ongoing that are exploring intraperitoneal paclitaxel, including the Stopgap trial, which is one of the trials that one of my colleagues is conducting at the University of California, Irvine, where patients are getting 5-FU plus IP paclitaxel. And this is somewhat similar in concept to the Phoenix GC2 trial that's being run in Japan right now. And so this is sort of the design, the study design. And the reason this is interesting is because there's some unpublished data that has just come out. And I think there's a NCI cooperative group, the ECOG, which is really pushing this forwards. And so hopefully this trial is actually going to get approved as a multi-center trial that we're hoping to open at Yale as well. But this is basically the Stopgap 1's concept, where patients get a laparoscopy. If they have peritoneal metastases, they get 3 to 4 months of chemo, laparoscopy, IP port, and then they get IP-IV chemo for 3 months. And if they have a good response and low PCI, they underwent cytoreductive surgery and HIPEC. And if they have progression, they continue on with either chemotherapy. And if they're stable, they stay on IP. And this is sort of very telling. Some of these, studies are fascinating because over here, you can see the right diaphragm right here. And this is after 4 cycles of IP paclitaxel. And you can see a fairly dramatic response to the right diaphragm over here. Similarly, these lesions that are life-threatening for patients, which are bowel, seromesenteric lesions, you can see this is the cirrhosis of the bowel, the mesentery of the bowel, and this lesion that's causing this bowel obstruction that has a pretty good response with the IP chemotherapy as well. So fascinating sort of a look, and this is the preliminary data that allowed the NCI to consider this clinical trial for a cooperative group trial. But essentially, progression-free survival of 14 months and median survival still not reached at this point for this study, and about 7 of 20 patients undergoing cytoreductive surgery. And so this is the design of the stopgap 2/3 trial, which is essentially the same concept, getting randomized to either getting an IP port or continued systemic chemotherapy with the ability of going on to have cytoreductive surgery if the PCI score is low. So very fascinating sort of a study design that hopefully will be open soon. I think just quickly switching gears in the last minute or two, we have been involved in leading a consortium and really thinking about how do we bring care of patients with peritoneal metastases in a somewhat more standardized way. Jill has been an integral part of this and has helped us tremendously with this. But really bringing together a big group of folks across the country, numerous experts, residents, and this was led a lot by our Yale residents who have really done a remarkable job with this. But we came up with a pathway that really focuses on peritoneal metastases, and you can sort of see the concept that as a group nationally that, thinking about gastric cancer with peritoneal metastases, really identifying the patients that may benefit from intraperitoneal chemotherapy. So essentially those that have low PCI scores or low peritoneal cancer index who get staged, have low PCI and do not progress on it are the folks that ideally get either cytoreductive surgery with HIPEC or gastrectomy with intraperitoneal chemotherapy. And so I think this is really sort of the focus of this population. And the goal is with intraperitoneal chemotherapy, can you actually convert these folks to low PCI? So I think it's a very interesting concept. I think our MED-ONC teams came up with systemic therapy regimens. I think this is very parallel to the NCCN guidelines, and you heard this from Jill already, ensuring that targeted therapies are included. And so I think the space of gastric cancer with peritoneal metastases is evolving actually fast and in parallel with gastric cancer metastases that are non-peritoneal. So I think it's a fascinating space overall. We do think peritoneal metastases are unique in their molecular signatures and the biology of the disease, and therefore lend themselves to local regional therapies such as intraperitoneal chemotherapy, whether it's HIPEC, PIPEC, or NIPEC. And I think we're hoping to continue the investigation of this space and lead these efforts here from Yale as well. And so if we have a big group of our surgical oncologists, medical oncologists, radiation oncologists that are really excited in this space. These are some of my colleagues that we take care of patients with gastric cancer, both primary localized tumors or metastatic tumors. And if any of you have any questions or want to reach out or ask more, learn more about any of these studies that we've talked about, this is my cell phone and email, so please feel free to reach out. But thank you again for your attention.
That was great, Kiran. I think we have time for a couple of questions. I'm going to ask one. So do you see a role for intraperitoneal biologic therapy, given all these biologics that are coming onto the scene, biomarker-driven therapeutics?
I think one of the biologic agents that has shown very interesting promise in intraperitoneal metastases is anti-VEGF. So bevacizumab intraperitoneally has actually found some very interesting responses. And in fact, when in a preclinical data, and then recently in a phase 1 trial, when surgeons have gone back after intraperitoneal bevacizumab, they've seen some really dramatic responses. So I do think that there's clearly some benefit to that. I think for targeted therapies like Claudin 18.2 or intraperitoneal immunotherapies even, I think that space is also being explored right now. So intraperitoneal checkpoint inhibition has now been explored in ovarian cancers with some interesting responses. I wouldn't say it was a great trial and didn't show phenomenal response, but it was interesting that there were some patients who had high CPS scores who actually had tremendous responses. But it wasn't uniform, even though the trial was done in patients with they were agnostic to their MSI status. So I think it's going to be very exciting. The beauty is that the toxicities can be much lower. And so an example of that is, say, for instance, CAR T cell therapy against mesothelin. So like mesothelin, ubiquitous, and if you give it IV, it causes systemic problems. But when given IP or intrapleurally, can have tremendous responses. So finding those biomarkers, like EpCAM is a very common thing for gastric cancer, peritoneal disease. So can we use things like that to target it? So I do think there's no question it's a nice space to investigate.
Great. Okay, so we'll now move to our final talk for the evening. And I'm really very delighted to introduce my colleague of many, many years, Dr. Kimberly Johung. Dr. Johung is an associate professor in the Department of Therapeutic Radiology, and she is also chief of the Gastrointestinal Radiotherapy Program here at Yale and Smilow. And I would also add that Dr. Johung, for her entire career, has been very actively involved in education of our students and residents, and she does serve as the vice chair for education. And she's very busy as director of the residency training program in therapeutic radiology. She and I have shared many, many patients over many, many years, so it is truly a pleasure to have Dr. Johung here tonight as our final speaker. And the title of her talk is Radiation Therapy and the Management of Esophageal Cancer. So we're going to pivot away from gastric and end with esophagus.
Thank you so much, Jill, for the introduction. And yes, we have shared many patients, and we'll share many more, including the ones we saw today. So I know it's late. I'm going to try to touch upon some of the older data just for context briefly and focus more on studies in the last few years and some new programs coming to Yale that involve radiation therapy in our esophageal and gastric cancer patients. So let's go into slideshow mode, and here we go. So radiation therapy in the management of esophageal cancer. So we all know radiation therapy is the use of ionizing radiation to damage DNA, leading to cell death. This occurs by both a direct and indirect action shown to the right, with really the most common lethal effect being the production of DNA double-strand breaks. As you know, treatment of esophageal cancer, as we heard about today, includes 3 standard modalities: surgery, chemotherapy, and radiation therapy, and now with the addition of consideration of adjuvant immunotherapy. So as a radiation oncologist, I'll obviously be focusing on the role of radiation therapy in the multidisciplinary management of these patients, and then also a bit on how advances in radiation techniques may impact outcome for our patients. So trimodality, standard of care for esophageal cancer patients with locally advanced disease who are operable candidates. The most recent trial to support this is, the well-known cross trial, including patients with T1 to T3 disease. Of note, 75% adenocarcinoma in this population, randomized to pre-op chemoradiation. That was carbotaxol, slightly lower dose, 4140 gray, prior to surgery versus surgery alone. And here we see that significant survival benefit. Pass CR rate of nearly 30%, and an increase in R0 resection rate with no significant differences in post-op complications or mortality. I think one thing that we all remember from this trial is the difference in response by histology, right? So pass CR rate of nearly 50% in squamous cell carcinomas compared to just under 25% in the adenocarcinoma population, which is, as we know, more common in the US and Western countries. Similarly, the survival benefit was increased in the squamous population, looking at a median survival of 82 months, right, compared to 21 months. So I think it's important to keep these response rates by histology in mind when we're thinking about selection of concurrent chemotherapy, management without surgery, things that we'll be talking about in a few slides. This is, a similar trial looking at pre-op chemoradiation compared to surgery alone that was conducted in China. And I think, it addresses a couple of issues in the cross trial, one being that population was predominantly adenocarcinoma. This trial was all squamous cell carcinomas. Similarly, similar randomization. The other thing that we'll note from this trial is the R0 resection rate, which was a little bit lower than expected in the cross trial. The surgery alone arm here is 91%, and we still see that significant improvement in R0 resection rates, but similar to the cross trial in a squamous population and overall survival benefit to pre-op chemoradiation supporting trimodality therapy. So for adenocarcinomas, a study that we also all know looking at therapy for this population is the CLGB trial, which was really exploring whether outcomes for trimodality patients could be improved with PET-directed therapy. The study population, as I said, was all adenocarcinomas, looking at those of the distal esophagus or GE junction, randomized to induction carbotaxol or FOLFOX with an interim PET, and responders continued on the same chemotherapy, with non-responders crossing to the other chemo arm with their concurrent radiation. and all patients going on to surgery after pre-op therapy. So, the primary endpoint looking at efficacy criteria, that was met for an improvement in pass CR rates among patients who were PET non-responders and crossed over their chemotherapy. We know that pass CR rate correlates with improved survival, and what was impressive was the pass CR rate of 40% in the patients receiving induction and concurrent FOLFOX, which really is the highest we've seen so far for the adenocarcinoma population. So median overall survival improved in PET responders as expected, and not reached for the FOLFOX PET responders. So I think, the intent of the study was to evaluate PET-directed therapy. In practice, I think this can support the use of FOLFOX with concurrent radiation for the adenocarcinoma population. So induction chemotherapy was used in both arms of this study and in others, and we see this in practice a lot. And so our Yale group did a study looking at a retrospective study to determine if outcomes are improved with induction chemotherapy in our trimodality patients. So these were patients who received pre-op intent chemotherapy prior to chemoradiation, compared to those who received upfront chemoradiation, with a median follow-up of about 3 years, and seeing no difference in progression-free survival or overall survival, no difference in path CR rate or end stage, downstaging or regression. In the adenocarcinoma subset, which made up the large majority of the study population, and also on multivariate analysis, there remained no difference in survival benefit to induction chemotherapy. So obviously a retrospective single institution study, but at least in our population, we were not seeing a survival benefit fallout with the addition of induction chemotherapy. Despite this, induction chemo we still often use commonly in practice, particularly for patients, right, who have significant dysphagia, may not tolerate radiation well without some initial response to systemic therapy. Okay, I'm going to move more into treatment of locally advanced adenocarcinomas. So standard of care for gastric cancer is perioperative chemotherapy, as Dr. Lacy was discussing in her talk. And because distal esophageal cancers and GE junction cancers were included in many of the gastric cancer trials, the issue of whether trimodality therapy or perioperative chemotherapy is a better approach for these patients has remained a topic of debate and one we were still discuss in tumor board many times. So right, we know that from the MAGIC trial, there's an overall survival benefit to perioperative chemotherapy. This was ECF compared to surgery alone. More recently, the FLOT trial demonstrated a survival benefit to FLOT compared to ECF. There was an earlier trial that was small, German trial, comparing pre-op chemotherapy to pre-op chemoradiation, so almost a peri-op versus pre-op chemoradiation comparison in GE junction and gastric adenocarcinomas. The path CR rate was improved with the chemoradiation approach. The survival benefit that was a strong trend, but did not fall out as significant. But this was a small study, as I said, underpowered because of its poor accrual. So the years-long debate, right, of peri-op chemo versus trimodality therapy, I think, was addressed in this neo-aegis, however you say it, that's how I've been saying it, trial, which was published recently. And so this is a trial looking at esophageal or GE junction, all adenocarcinomas with locally advanced disease staged by EUS and PET scan, randomized to cross-trial preoperative chemoradiation, the regimen of carbotaxol and RT to 41.4 gray, versus the MAGIC type regimen of perioperative chemotherapy, which was predominantly the ECF, ECX, but FLOT was added when that data became available. In the peri-op chemo arm, 40% of the patients completed the complete treatment regimen, whereas in the trimodality arm, up to 80, almost 90% of patients completed the full treatment regimen. Fewer patients on that arm withdrew due to toxicity. We see that the path CR rate was better with trimodality therapy. The R0 circumferential resection margin rates were better with trimodality therapy. But there was no difference in overall survival or disease-free survival. If you look at patterns of recurrence, no difference in locoregional alone, systemic alone, combined recurrences between the treatment groups. No differences in operative mortality as well. There were global health status and a measure of physical emotional functioning was assessed. That seemed to deteriorate more in the trimodality group. I think it's important to note, right, that the trial did not complete accrual, in part due to an interim futility analysis, also the impact of COVID. So it's underpowered for the endpoint of assessing the non-inferiority of perioperative chemotherapy compared to a trimodality approach. But the results do show equivalent outcomes. And this is so equivalence between perioperative chemo and trimodality in terms of survival. And this is using the cross regimen for adenocarcinomas, right? So carbotaxol, which was shown to be inferior to FOLFOX in the CALGB PET-directed therapy trial, and also a lower dose of radiation than we typically use, which is the preoperative 4140 dose that was used in the cross trial. And in practice, we most often use 50 gray. So perhaps the trimodality arm, with FOLFOX, or we might see better results using a different chemoradiation combination and total radiation dose. Okay, so another advance recently in trimodality therapy was shown in this checkmate study. So this was evaluating the use of adjuvant immune checkpoint inhibitor therapy in the trimodality population. So here, patients with esophageal or GE junction cancers who had received standard chemoradiation and had path residual disease after an R0 resection were enrolled regardless of their PD-L1 expression status and randomized to a year of adjuvant nivolumab versus placebo. Disease-free survival significantly improved regardless of histology or PD-L1 CPS score or the radiation dose that was used for these patients. Driven probably by a decrease in distant recurrence, improvement in distant metastases-free survival, but there also was a local regional recurrence, a decrease in local regional recurrences with the use of adjuvant nivolumab. So I think because of this trial, it's kind of this that you tell your patients you're going to get through trimodality therapy. Am I done? But it depends on what the pathology shows. And I think adjuvant checkpoint inhibitor therapy now is standard consideration for trimodality therapy patients with path residual disease. So what about outcomes without an esophagectomy, right? So patients often see the surgeon, they come back, and it's hard for them to accept, what the long-term quality of life type changes are and the risks of esophagectomy. So this data will pertain to patients who are either not operable candidates or would prefer or decline to avoid surgery or decline surgery. Right, so we know from the old Herskovitz RTOG study, classic study, looking at chemoradiation compared to radiation alone, that there can be long-term survivors after definitive chemoradiation. These were all patients with squamous histology randomized to cis-5FU radiation versus radiation alone, and chemoradiation did provide a survival benefit, and we do see 20% of patients who are alive at 10 years after definitive intent chemoradiation. But even in those patients receiving concurrent therapy, we still have a challenge with local control. 25% had persistent disease. Nearly half of them developed local failures. So subsequent trials asked whether local responses and survival can be improved with dose escalation. This is an older intergroup trial looking at a dose of 50.4 gray to 64.8 gray with no difference seen in local control or overall survival. I think really probably we can't make much of this trial now because the radiation techniques used would be considered outdated, right? Large radiation fields, outdated techniques, making it possible that maybe there is a survival benefit or a local control benefit with dose escalation in the modern era. So this is one such study of many looking prospectively at dose escalation using IMRT, intensity modulated radiation, where we're better able to carve the dose away from normal structures. Chemoradiation was delivered with a simultaneous integrated boost, meaning the gross disease got a slightly higher dose with IMRT, And it was reasonably well tolerated. If you look at there are no grade 4 or 5 toxicities, with encouraging local control rates when you compare to a contemporaneous institutional cohort. So this was evaluated in a more recent randomized trial, the Art Deco study. So this is 260 patients. They were either medically inoperable or unresectable. A large fraction of these patients, so 44%, were unresectable due to proximal cervical location of the primary tumor, which is a subgroup where we often had considered treating those patients like head and neck cancer patients where they aren't surgical candidates due to the location of the tumor. And we consider dose escalating into the 60 to even 70 gray range. So Art Deco compared a dose of 61.16 gray compared to a standard 50 gray dose with concurrent carbotaxol. And here again, even with the use of IMRT in the modern era in a randomized setting, dose escalation did not improve local progression-free survival or overall survival in both squamous cell and adenocarcinoma patients. So I think as of now, dose escalation doesn't seem to be our route to improving outcomes. What about trimodality therapy compared to definitive chemoradiation? Or what is the benefit of adding surgery after chemotherapy? So we have 2 earlier trials and 1 recently presented trial at ESMO to address this question. This is an earlier French trial, population of mostly squamous cell carcinoma patients who received chemoradiation. It was delivered to 43 gray or a split course regimen to 30 gray. Those with a clinical response were randomized to trimodality therapy with an esophagectomy versus the other arm continuing on chemoradiation. And the take home is that local control was significantly improved with a trimodality approach. So was perioperative mortality, though, and so the addition of surgery did not provide a survival benefit. A similar German trial randomized patients with squamous cell carcinoma of the esophagus after induction chemo to chemoradiation, followed by surgery or just dose escalating the chemoradiation, so chemo-RT alone, again showing local control benefit, but not a survival benefit with that higher post-op mortality. SANO trial is more recent. This was presented at ESMO. This was a non-inferiority trial comparing active surveillance and surgery for salvage in salvage setting to esophagectomy right after chemoradiation in patients with both adenocarcinoma and squamous cell carcinoma. So patients were assessed for a clinical complete response after cross-regimen type neoadjuvant chemoradiation. Assessment was done by EGD with random biopsies at 4 to 6 weeks, and then a delay with repeat EGD and biopsies, EUS and FNA of any suspicious lymph nodes, and a PET scan to rule out metastatic disease and assess response at 10 to 14 weeks, which was a regimen that had been evaluated prior to the study in a pre-SANO study. So if patients had a complete clinical response, they were randomized to active surveillance or surgery. Active surveillance consisted of the same regimen of PET, EGD, and EUS at the intervals shown on this slide. 1/3 of the patients maintained a clinical complete response, approximately 1/3. Nearly a half developed a local regional only recurrence and underwent surgery. And the remainder recurred with metastatic disease. The study reported overall survival from the date of the clinical complete response, and overall survival with active surveillance was non-inferior to standard surgery following chemoradiation. There's also no difference in R0 resection rate or 90-day post-op mortality. Disease-free survival, rate of developing distant metastases, also not significantly different. Looking at global health-related quality of life, as expected, that was better in the active surveillance arm. So I think, this data has the potential to impact practice. Certainly looking forward to the publication. Things to note, right? The data stratified by histological subtype was not presented, so we don't know if the response is being driven by the squamous cell population, for example. Important to consider whether then it would apply in the adenocarcinoma subset. You would presume that a large fraction of patients were not complete responders and went on to upfront surgery. Right. And in their assessment for complete clinical response, it was 2 stages, EUS and EGD at 4 to 6 weeks, and again at 10 to 14 weeks, leading to a delay to surgery for those patients who did not have a clinical complete response, perhaps impacting the outcome for those patients. So points to look for when we see the final publication. Okay, so I'm going to switch gears a little bit and talk about advanced radiation techniques and 2 platforms that have the potential to impact outcomes for esophageal cancer patients that are at our cancer center or coming to our cancer center soon. So in the past 2 decades, we've seen the utilization of advanced radiation techniques such as IMRT or proton therapy dramatically rise. What's the difference with protons? I think we all know at this point, protons have a defined range in tissue, whereas photons continue to deposit their dose beyond the tumor target in the normal tissue as shown here. So it's a way to help avoid sending dose to the surrounding normal tissues. A common problem we have with the radiation of esophageal cancers is there can be a significant tumor length or nodal burden requiring large radiation fields. And protons can improve or have the potential to improve target coverage, significantly reduce radiation dose to adjacent normal tissues, such as the heart, the lungs, the bone marrow, to try to reduce treatment-related toxicities and sort of widen that therapeutic window. You see a comparison of a proton plan versus an IMRT plan, and there really is a similar high dose distribution around the tumor, but what you can appreciate is a significant reduction in the low to moderate dose exposure. So in a study that was looking at patients treated with trimodality therapy at MD Anderson, they saw that pulmonary and GI post-op complications were reduced both with IMRT and proton beam therapy compared to standard 3D techniques. This is a study at Mayo demonstrating a reduction in grade 4 lymphopenia from reduced bone marrow exposure with protons compared to using photon IMRT or 3D radiation. There was a retrospective study done comparing definitive chemoradiation with protons or IMRT, and this was looking at outcomes. So we are seeing a decrease in toxicities. Do you see an improvement in outcomes? And in this retrospective analysis, overall survival, progression-free survival, distant metastases-free survival, local regional failure-free survival, all improved with the use of protons. So these types of retrospective studies led to a phase 2 randomized study that was conducted at MD Anderson, addressing whether these dosimetric benefits of proton beam therapy versus photon IMRT can be associated with improved clinical benefits to justify the obvious higher cost of proton beam therapy, and also whether protons can reduce the severe treatment-related toxicities, but without impacting disease outcomes. So these are patients with stage 1 to 3 esophageal or GE junction cancer randomized to protons versus IMRT. About 50% of them ended up being treated with definitive chemoradiation, the other half receiving trimodality therapy. The primary endpoint was progression-free survival on this total toxicity burden, which is detailed on the right, but a composite score quantifying basically the extent of like cumulative adverse events and their severity. And what they found was more adverse events were seen in the IMRT group, particularly severe post-op complications like ARDS and pneumonias. The endpoint, the score of the total toxicity burden was reduced with protons. Mean hospitalization time was also reduced with protons and grade 4 lymphopenia, but no difference in progression-free survival, overall survival past CR rate. So no better, but also no worse, and reduction in toxicities. So this leads to an ongoing NRG trial with GI006, currently accruing, comparing trimodality therapy with protons versus IMRT and concurrent carbotaxol. Primary endpoints here is determining whether overall survival is improved or non-inferior with protons, whether grade 3 or higher cardiopulmonary toxicities are reduced with protons. And I think what we hope to see is whether there are advantages with proton therapy, such as allowing for safer trimodality therapy with reduction in toxicities, perhaps again reevaluating dose escalation with proton beam therapy, and whether in that setting we can see an improvement in outcomes, and certainly applicable in the retreatment of locally recurrent esophageal cancers. I'm happy to say that construction is now, I think, officially underway on our Connecticut Proton Therapy Center. This is a joint venture with Hartford Hospital. We have an address, a sketch, and ground has been broken. And we can expect this to open for treatment of our patients in about 2 years. Okay, so last few slides, I'm going to discuss a new platform at our cancer center that has the potential to impact the treatment of patients with stage 4 disease. Before talking about the technology, I will note that our Yale group also did an analysis of metastatic esophageal cancer patients, 12,000 of them in the NCDB, who received radiation, and what was the outcome. So about a third of metastatic patients received esophageal radiation. This is a population treated between 2016 and 2019. The median dose was palliative, as expected. On propensity score matched analysis, radiation was not associated with a survival benefit, but we do know for these patients that radiation can significantly palliate local symptoms, particularly dysphagia or bleeding from the primary tumor. Where radiation may impact outcomes for stage 4 patients is in the setting of oligometastatic disease. Less common for esophageal cancer and gastric cancer patients, but certainly something we can see and do see. We know from the SABRE-COMET trial that in patients with 1 to 5 metastases, where the primary tumor was controlled, and this included multiple primary tumor types, but most commonly breast, prostate, colorectal, and lung cancers. Overall survival and progression-free survival were improved with SBRT to all oligometastatic sites compared to continuing on palliative standard of care treatment alone, with a median survival of overall survival of 41 months with SBRT to all oligometastatic sites, a really complete ablative therapy, compared to 28 months with standard of care therapy. So promising survival outcomes with local control and therapy to oligometastatic disease. So earlier this year, and actually our first case was just a few months ago, Yale New Haven Hospital became the first hospital in the Northeast to offer what is called biology-guided radiation therapy. So we're one of the first 5 cancer centers in the nation to offer this, and the first in the Northeast. So what is the reflection? What's so special about it, other than the fact that you get to lie in a tube that glows neon blue, right? So let me explain. So with standard SBRT, the radiation field is typically expanded to encompass the path a tumor would take. So here we're imagining, say, a lung oligometastatic site. So this tumor is going to move during respiration, and so therefore our standard approach is to expand the field to encompass the path that a tumor takes during respiration. What the reflection does is it tracks the PET tracer emissions from cancer cells in real time to precisely determine where to direct the radiation, even if the tumor is moving during treatment. So that's what has been termed biology-guided radiation therapy, or BGRT. So with BGRT, the treatment field is not enlarged to encompass tumor motion, but rather the PET signal from the tumor is tracked by the machine such that the radiation delivery moves along with the tumor target. This means that a patient will have PET tracer injected for their planning CT and PET tracer injected prior to each fraction. So it's basically a limited PET scan at the levels of the tumor that allows the reflection machine to detect the signal from the tumor and turn on the beam and move the plan with the tumor as it moves with respiration. So this reduces the volume of normal healthy tissue exposed to high doses of radiation, and it would follow that you could expect that this would reduce side effects. So we do have a registry trial open for all of our patients who are receiving BGRT at YCC. We look forward to trying to advance the treatment of patients with oligometastatic disease with this technology, and hopefully this will impact some of the esophageal and gastric cancer patients, since that's our topic today. So I'm going to end there because I know it's getting late, and we can probably turn it over to questions for anyone at this point, Jill, right?
Yeah, thank you, Kim. That was great. And I really appreciate that clear explanation of Reflexion. And now I think I understand it a little bit. So we are at time, even just a few minutes over. There was only one question left in the Q&A about eradication of Helicobacter pylori in patients with gastric cancer. And it's really unclear, as best I can tell from the literature, how the Helicobacter pylori influences the prognosis and response to treatment. But we do generally want to eradicate H. pylori. It may alleviate H. pylori-related symptoms and improve quality of life, reduce risk of transmission to family members. And in patients who undergo a gastrectomy or partial gastrectomy, there is evidence from retrospective cohort studies that it does improve prognosis to eradicate H. pylori. If any of you who are still with us this evening, please feel free to address any questions to us via email. We're happy to answer any additional questions. And thank you all for staying this evening as we're heading into a long weekend. We'll let you get back to your family and dinner and other plans. And thank you for attention tonight.
Thank you so much, Jill. Thank you so much, Kiran.
Thanks, everyone. Bye.